Welcome to Brain Wellness, the podcast. I'm your host, Mandy NP. Each episode will bring you a new topic or interview related to brain health and wellness as part of my mission to help you on the path to a healthier, happier brain. So, let's get started. Hello, everyone, and welcome back to another episode of Brain Wellness, the podcast. My guest today is Dr. Vincent Schaller. Dr. Schaller is a board-certified physician with over 30 years of clinical experience. He's been a certified ImPACT consultant for over 15 years and is the medical director for the Mid-Atlantic Concussion Alliance, which he founded in 2010 to meet the growing needs of concussion and TBI patients seeking treatment in his region. Dr. Schaller and his staff have treated over 17,000 concussions and TBI patients. Their pursuit of the latest technologies and neuroscience have allowed the MAC Concussion team to bring the latest treatment, care, and protocols to better care for their patients. These currently include BrainScope EEG, RightEye, brain SPECT Scans, Ocular Therapy, HBOT, which we'll talk about, I'm sure, sway balance systems, Creyos Health and ImPACT. He's also a longtime voice and advocate for the TBI community. I'm honored to have you here today. Thank you so much, Dr. Schaller.
Thank you for having me.
Yeah. So we got talking a little bit before I hit record, and I wish I would have recorded because we're going to ask some of those same things again. But for my listeners, I always love to start out getting kind of the background. What got you into what you're doing now?
So I was actually, I'm board certified as a family physician, and I've been caring for concussions for now over 30 years, but not with the technologies or the latest education and understanding of how to identify and then recover a concussion or TBI. So I was I owned an urgent care center in northern Delaware from 2003 to 2013, and during that time period, when you're open, 365 days, if someone's having a post TBI headache, they usually show up on your doorstep, Friday morning or Saturday morning, Sunday morning. So we started seeing the need was there because people were having head injuries, and then they were coming in with these long-term symptoms that just couldn't be resolved. And what frustrated us was that we, in the old days, brain rests, just rest for a week or two and then go back to work and school and see what the heck happens. And so because we were seeing so many sports-related concussions through the local high schools, local middle schools, and even the colleges and universities in our area, we started realizing that these folks weren't getting better, in 7 to 10 days, like it was being told by certain individuals and certain professionals in the community. And I was like, they're not getting better in 7 to 10. And if you don't do anything, 3 months later, you're still got someone with bad migraines or having a hard time with a computer screen or can't get back to their job, can't get back to school. And so at the first instinct was, okay, I'm going to reach out to my neurology friends and get them plugged in and say, hey, this is a really bad concussion. Could you please help out? And when I would call my neurology friends, they would say, well, we'll see them in about 3 months. And I was like, but they're out of school. They're not working. 3 months is a long time. I mean, you could lose education could be set back. You could lose your job in 3 months. 3 months is usually the limit for FMLA. So I said, what can we do better? And they were like, I'm sorry, we'll have to wait 3 months. And so at that point, I realized as the cases kept coming in, we were seeing steady concussion cases. But what really hit was around 2005. Students were coming in from the local universities and the local high schools, specifically the football players. And over like a football season, they were coming in saying, Dr. Schaller, can you please do my ImPACT test? I had a baseline, but I need one because I think I had a concussion. And so I was like, ImPACT test. That sounds interesting. And so I did a little research on ImPACT. And by the end of the winter, or the end of the football season, it was probably over 50 students because ImPACT had really penetrated the market and got a lot of baselines out there. And I said, that many people showed up at my doorstep in 2005 because of this ImPACT program. I got to check and see if it has any benefit because I already know we have a problem with concussions and treating them and finding a home for them and finding a place they can get better. So it led me to I started investigating the ImPACT program to make sure I wasn't walking into something which was just, a moneymaker. So I researched it and I found Dr. Berkner from Colby College up in Maine. And he was one of the biggest users of ImPACT. And so I gave him a call and asked him, is this legit? How are you using it? And he talked about they set up an entire network in Maine, all the schools and the doctors treating concussions, so they could share the ImPACT baselines. So when they were injured, they could do the post-injury and would have the database to quickly access the baseline. Because at that time, you had to have all these passwords and stuff, and each of the data was stuck with the schools. They weren't sharing them with the doctors. So we started working with the folks in Pittsburgh, and I drove out there, met Dr. Mickey Collins, Dr. Mark Lowell. They were the ones that actually created ImPACT for the Pittsburgh Steelers, worked with Dr. Maroon at that time, who was the team doctor. And they developed this thing on a local computer system. Actually, it was paper, then computer. And this, remember, this is the time of the advent of the internet. And then when they put it on the internet, that's when it popped. And so by the time it hit 2005, it was designed beautifully on the internet. All the research was done. And it was a good product. It was a good product to baseline and to see if the athlete actually dropped in performance. And the cognitive drop is important because that affects academics. And the cognitive drop affects being able to be employed or being able to keep your job. So at that time, ImPACT was FDA approved from ages 5 through, I think it was 85. So we were like, okay, let's apply ImPACT to the entire population. Let's give it a whirl, see what happens. So when I went out to Pittsburgh, they said, this is what we're going to teach you. And so they taught me not only the ImPACT test, which was their tool, their measuring tool, but they taught me about ocular therapy, vestibular therapy, prescription therapy. It was interesting how they were able to involve prescription therapy during the recovery to cool the brain down, help it recover quicker, help with insomnia, prescriptions that would help with anxiety, depression, or how to adjust them. And I'd done a lot of treating migraines and treating anxiety, depression my entire career. That's what I was trained to do as a primary care doctor. So for me, it was a natural fit. All the medicines they were using out there, I'm like, well, I use those. I use those on a regular basis. So I did about, back then it was not on the internet. Back then training with getting ImPACT certified was an in-person event. So, and you had to do 2 oral exams. You had to literally learn the program, go to all the conferences, take all their tests, and then you had to go back and see 50 patients. And then you had to present on an oral exam, those 50, you pick a sampling of those 50 patients. And that's how I got certified for ImPACT consultant. So this currently now you can literally go online and do it remotely. So that way they made it so the platform's easier for people all across the U.S. to get and even internationally. But I ended up doing it the old-fashioned way. And when I was done, they said, you have permission to train people in your area because you did it, hands-on, and rounded in the clinics with Dr. Collins and saw how they applied the technologies and saw how it worked. It was really an eye-opener. And seeing the patients get better and watching their scores improve and their exam clear up, really the light bulb went off. And so I brought that technology back. So I wanted to be like Dr. Berkner at Colby College. So I said to the ImPACT company, I said, I'd like to share. Because I was a medical director at that time of 24 schools in the area, in Delaware, Maryland area. And they said, well, Dr. Berkner made the Maine Alliance. What's your area of the country called? And I go, it's the Mid-Atlantic region. And they go, why don't you make the Mid-Atlantic Concussion Alliance? And I was like, maybe I should check with my wife first. That sounds like a big responsibility, but I took it and ran with it. And we started creating a network with physical therapy groups. I started lecturing to the PT groups, ocular therapy groups, hospitals, lectured to the schools in the area, trying to bring the technology to explain you can do a vestibular ocular motor exam. You can check near point convergence, saccades, VOR with no equipment, and you can diagnose a concussion with if you get really good at the VOMS exam. So then I started teaching the VOMS exam to the athletic trainers in the field, PTs and OTs, to local doctors. Went through a whole network of urgent cares to teach them how to do a VOMS exam in their offices to be able to at least identify the concussion. And did that for about 12, 13 years, still lecturing. But it made a big difference because when I first brought back the technology from Pittsburgh, I couldn't find a physical therapist that actually knew how to do vestibular therapy, balance therapy, ocular eye tracking therapy. And by the time I was done, the NovaCare network picked it up and said, hey, we're going to train all our people how to do the therapy for the concussion patients. ATI picked it up. Pivot, which is now Athletica, they picked it up. Phoenix Rehab picked it up. I Rehab. So over the time period, I felt really confident that I could now refer my patients out to a local PT group. I don't have to pick the one person in the area that knows how to do it. And so I'm really happy that that's how it turned out. And then ocular was always a problem. Dr. Mickey Collins always said to me, he goes, if you can find a good ocular therapist in your area, he goes, that's going to be your biggest challenge, when he knew I was setting up the network. And boy, was he right. And we now have about 30 good ocular programs throughout the 7 states that we care for. And we know where to send them, but it makes a difference. If you get someone who's really good at ocular therapy, you plug them in, you can watch those right eye infrared eye tracings just clean up beautifully. And makes a world of difference if your job's in front of two computer screens. So, but that's kind of what ended up happening is my urgent care center got bought out by a large network, which is what all the small urgent care centers ended up happening to. And but the people I sold it to, Premier Urgent Care, I said, I want to build my clinical network across your 14 urgent care centers. And so I did that. And then I grew it across the AFC urgent care centers. And then we just blossomed into having our own office and started putting everything under one roof.
Very cool. That's quite a long journey to get there. But when I see what you're doing now, it looks like it's all been worth it.
It really has. And, I'm 30 years in the clinical practice, and to have something this new, this exciting, and quite frankly, my brain is constantly being stimulated by every patient's a puzzle. And the one thing Pittsburgh taught me is every concussion is like a snowflake. Every concussion is unique. And, because the brain has 80 billion nerve fibers and multiple lobes and hemispheres, and it literally, you could injure over here versus here. It's a different presentation. Injure here versus here, or injure where the brain actually twists. A torsion injury, brain stems involved totally. Every concussion has a different challenge. And when we know what area the brain's involved, that's when it really gets fun, because in that way you can really target your therapy, knowing what area the brain was injured. And the technology, fortunately, is there to be able to do that. The access to that technology sometimes has hurdles with the insurance industry. So we do everything we can to get that technology to our patients.
Yeah. And so kind of as we were talking a little bit before too, in your bio, you list all these different technologies. Which one of those technologies can actually be used to diagnose a concussion? Because some of them I've heard of, some of them I've not. But for my listeners, can you describe that?
Excellent question. So you get yourself in trouble legally if you say that I'm going to use this one test to diagnose a concussion. And because legally there's all FDA approvals and stuff like that. And so to get an FDA approval, you have to have it specifically what you're going to approve it for. So the best way to explain it is that the concussion, and this is how I was trained from day one at Pittsburgh, multiple ways to evaluate, to make the conclusion there's a concussion. You can't just say ImPACT can diagnose a concussion, which is a neurocognitive test I made at Pittsburgh. We actually have two neurocognitive tests. We also use Creyos, which was known as Cambridge Brain Science testing out of Toronto, Canada. So the reality is that you can't just use those tests and say, oh, we have a concussion, this test is abnormal. No, you have to combine that with a VOMS exam. Do they double vision outside of 3 inches? Do their eyes track smoothly, or do they have a wiggle and a nystagmus on horizontal vertical? Do they have a problem with VOR balance as they turn their head and they're locked in on their thumbs? Their thumb moving? Is their head wobbling? So we really do have to vet the vestibular system, do a full VOMS exam. And teaching a VOMS exam is probably the biggest hurdle in getting this technology out there, because you need to do the VOMS exam on every visit, and you need to do the VOMS exam on the sidelines of the football field or whatever. And we actually have done that. I've been on football fields where someone gets clocked, bring them out. Oh my goodness, they're doubling vision at a foot. They're done for the game. They got to go see somebody and get taken care of. But the reality of it all is that it's a combination of tools. So we like to look at MAC's tool chest. Okay, so if you had a tool chest and all you had in there was a screwdriver, that's not much of a tool chest. You carry that around, you open up the lid and go, hey, look at my tool chest. And you see a screwdriver in there, you'd be like, well, that's not a tool chest. So, but what our tool chest has is, screwdriver, hammer, wrench, socket set, and that's what you have with a sway balance, FDA approved, ImPACT neurocognitive, FDA approved, Creyos, Cambridge Brain Science, RightEye, infrared eye tracking, FDA approved, BrainScope EEG, quantitative EEG, FDA approved. And then you go into your SPECT scans, and SPECT scans are actually approved by the American College of Radiology. Okay, so we have all these things that are you open our toolbox, you go, wow, that's a lot of tools. But they're going to, if you said, could you fix the job with that screwdriver alone? Well, maybe if you're MacGyver, you could. But the whole point is that the mindset should be for the clinician is you should have a complete tool set so that you can go into any concussion, which is unique like a snowflake, and you have an entire array of tools to be able to help that patient. So, but I don't fall into the trap of someone saying, hey, can you just diagnose it with one test? And the answer is no, you need to do a bunch of things. So, and that's kind of why in sports, you can't put up the blue tent and do all that inside the blue tent. So the reality of it all is that sports has to start evolving to do a quick VOMS exam in the blue tent. It doesn't look so good. You're going to the locker room so we can use additional tools. We can use, a neurocog test and let you calm down. And we can do a sway test, see how you're bound before you get but the problem is they go into the blue tent, they're back on the field and you're like, eh, they got knocked out or they were wobbling. I mean, that's a concussion out of game until proven otherwise. And that we have to get better at. So, and that's a whole nother challenge, but we're making progress, definitely making progress in the last 10, 15 years.
Yeah. Yeah. And kind of as we were talking before we hit record as well. So my accident was almost 22 months ago now, and I was taken to the ER from the car accident that I was in. And even in the ER, they did a head CT, and that was about it. I don't remember them doing any kind of visual tracking or anything. They never once used the term concussion. And I've been out of work now for 22 months. So it was clearly more than just a little soft tissue injury that they said from the ER. Where I'm assuming you faced some of that early on in your practice as well. Kind of what happens when somebody doesn't get diagnosed right away? I'm like, thankfully I had the knowledge and I reached out to one of my colleagues. But if I hadn't had that, what would a patient face if they were in that situation?
The problem is they could lose their job, unfortunately, especially if it's computer-based. And most jobs are computer-based now. Anyone that has a remote job, that's computer-based, okay? If they were in the middle of high school, they could lose an entire year of school, set them back, and that's a social hit and an academic hit. If they were in college, it could cost them money. I mean, you lose a semester and you're going to school, it's 40 grand a year. I mean, and then the emotional hit on the family, and then they have to get more student loans. And I mean, it affects every age group. It affects every age group of academics and every age group of schooling. And the sad part is that if we could do it better, and that's what we're all about. We're not perfect, but can we do it better? I would say that if I could get the American College of Emergency Room Physicians, get them on board to make sure all the residents and coming into their program can do a simple 5-minute VOMS exam. And if they trained it and they did the VOMS and go, oh boy, you double vision at a foot, or it can be trained. It takes time to learn how to do it. And I've trained many people. I always tell them, it takes you about 100 patients to get really good at it. So it's going to be a while if you don't see a lot of concussions in your urgent care center or wherever, or your primary care office. But the reality is if we could get the American Academy of Family Practice, American Academy of Pediatrics, American Internal Medicine Society, and the ER, we could get the people who are on the front line seeing the concussion as the very first medical person to see the concussion and diagnose it, then I think that the referral will be done. Now, you also have to have a decent concussion network set up in your area where there's people like yourself and like myself who are actually going to stay on top of the technology and make sure that we can see them in a reasonable time. Biggest challenge for us at MAC is we're growing fast, and we want to make sure the patient is seen within a week, maximum 2, for that first visit, because we know they're out of school or out of work most likely. And we'd like to see them early. We don't want to see them 3 months later when they're failing their classes in school. We don't want to see them 3 months later when they've maxed out their FMLA and they're losing their job and not knowing whether they should apply for short-term disability or not. There's a lot involved in. When we do concussion work, it's more than just clinical. There's a lot of it's like dropping a pebble in a pond. There's a lot of collateral damage that could go on if you don't get on top of it. But ideally, the ER should say you have a concussion. Okay, the ER should tell the patient your CAT scan's negative, but a CAT scan can only find bleeding, strokes, and fractures, and if tumor, God forbid. But a CAT scan is not a microscopic study. An MRI, as fancy as it looks, as beautiful as the pictures are, it's not a microscopic study. These injuries we treat at MAC are microscopic injuries. So how many MRIs are negative? 99.9%. And these people are still out of work in 3 months and still struggling with recovery. So the public needs to be educated. And I hate to say this, doctors need to be educated and providers need to be educated, because I've seen in the legal world, well, the MRI was negative. They couldn't have had a bad concussion. And I'm like, I'm just like, seriously? I mean, we're living in 2025. Have you picked up a journal article recently to check the latest technology? I mean, are you kidding me? But the reality of it all is that CAT scans can't show microscopic changes, which are broken nerve fibers. You break nerve fibers, it's on a microscopic scale. If you want to be really clear about it, there's never been a CTE patient with a positive CAT scan or MRI. Yeah. That is scarring on a grand scale, on a microscopic basis, invisible to MRIs and CAT scans. Dr. Maroon back in Pittsburgh Steelers, when they had Mike Webster, was the first person diagnosed with CTE. He did MRIs again and again and again and again on Webster. He felt helpless. He couldn't help the guy. The guy was spiraling down physically and emotionally. He was living in his truck, for goodness sakes, because he was had so much rage and problems. MRI was negative. So please, it'd be easy to educate someone and say, listen, if you can't see CTE on an MRI, all that scar tissue damage, why would you expect to see a concussion on an MRI? And we have to get over that. And then the ERs would be like, well, your CAT scan is negative, but the CAT scans can't show microscopic changes. My VOMS exam says you probably have a concussion, or even just the symptoms. You know, if they're throwing up in the ER, that's a concussion. You know, they weren't throwing up before the car accident or before the collision in sports. I mean, so did they have a fencing reflex? But a simple VOMS exam, 5 minutes. And I know the ER is busy. I know the waiting line's out forever and it's hours and hours. 5 minutes. So at least the person can leave there saying, well, my CAT scan's negative. I don't have a bleed, but I better find myself a concussion specialist. And they always say, go see your PCP, which is fine. But the PCP then needs to be educated to go, you've been out of school for 2 months. I need to access some of the special tools. Someone with a toolbox I need to access. And that's kind of what we would hope the PCPs would do. Or, hey, if they want to get trained to do what we're doing, all to them, all power to them. But it should go from ER, immediately told concussion, VOMS exam, whether the CAT says whatever it says. Then it should be PCP, who then is a gatekeeper that says, I can treat it here. I've got the technology here. Or no, I'm going to get you to PT right away. That should be done immediately. In the old days, they would say, well, I can't send them to PT. They still have a headache. They're still dizzy. And we're like, out of Pittsburgh, they're like, no. They
That's
go
why
to
you
PT
should.
within a few days. Well, they're going to throw up. No, they're going to, a properly trained vestibular and ocular therapist will nudge them to have symptomatic, but won't, if they're making them throw up, they're not doing it right. But the original part was like, my patients were like, I'm not going to PT. I'm nauseous. I'm like, no, you're going to PT. So that was another hurdle we had to overcome, you know, when we were starting and growing. But I really think if the ERs and urgent care doctors and nurse practitioners and PAs would do a VOMS exam, whether they did a CAT scan or not, just did a VOMS exam. And if you're in the urgent care world, everyone doesn't need a CAT scan. That's 250 chest X-ray equivalents. That's a lot of radiation. So, but if you do a good VOMS exam and say, listen, wake them up, you know, at midnight, wake them up maybe 2 a.m, there's your check for bleeding. Okay. You don't have to do a CAT scan. And the reality is that the CAT scan is only going to look for blood. So the only time you need to go back for the CAT scan to the ER overnight is if you start throwing up in the middle of the night when your pupils is large and you're confused. I mean, then you go back for the CAT scan and do that. So the reality of it all is that if every urgent care, primary care, ER did a VOMS exam, explain to the patient, I'm going to do a CAT, but it's only because I'm worried about bleeding. And then you need to get into therapy. And either your primary care doctor follows your recovery if they're up, if they have a good toolbox, or you go to a place that has a good toolbox so that way they can get things rolling here. Otherwise, what we used to say in the 1990s, and I was told in medicine, wait it out, you'll get better. The brain has a way of healing itself. The reality is when the poor brain goes boom, boom inside the skull, and I always pull out my little brain model with my patients so they can actually see it. But if you are in a car accident and you get rear-ended, so it's the front of the brain, temporal lobe side, back of the brain, occipital for the eyes, and cerebellum for balance. Good old brainstem is white down here. But if you get in a car accident and all of a sudden you're sitting minding your own business at a stoplight and something plows into you, here's what happens. Whether your head gets a cut, a bruise, it doesn't matter. You got 50 miles an hour coming, you're sitting still. All of a sudden your skull goes 50 miles an hour that way, smacks the back of the brain. Brain's like pizza dough. It's soft. It's going to hit the skull. Hard skull's going to go boom. Then it's going to bounce to contra coup, boom. Okay. And what's even worse is if you're at the stoplight looking over at your little radio or whatever to see what song's playing and who the artist is, turn your head just a little bit. Now it's a corner hit, boom, boom. And when you do a corner hit, the head spins, brain spins inside the hard skull, and that injures the brainstem. And that's where one of the tools in our toolbox, we can identify brainstem injuries versus not. The first thing I realized when I was getting trained and getting good experience was, ooh, these brainstem injuries, boy, they don't heal fast. They're like months and months. And I remember one case back in the day was a police officer, a Pennsylvania state police officer. He was escorting a car that was having a hard time on the ice on I-95 just by the Philadelphia Eagles Stadium, the link. And he was trying to safely get that car off into the shoulder. And as he was doing it, it was very icy that day. That's why that car was struggling. A car came up and spun out at like 65 miles an hour, smacked him into the guardrail, spun his car around. And the reason I remember the story very clearly was he's doing his job. He's just being a police officer. He's strapped in. He's got his seatbelt on. He's trying to help a disabled car and make sure the person's safe. He arrived at my, I was in an urgent care environment at that time. He arrived in my urgent care environment. So I was teaching the folks at AFC urgent care. And I did the exam. And he doubled vision at 1.5 feet. And I said to him, I said, this is going to be a long recovery. And he goes, what are you talking about? Can't I go back to work tomorrow? And I'm like, I said, you got a 1.5 foot convergence problem. I said, that means your brainstem was involved. So the way you were hit on an angle when you spun into the guardrail. And I said, that's a brainstem injury. And I said, that's 3 to 6 months or more. And he looked at me and he goes, seriously? And I said, yeah, 3 to 6 months or more. So what ended up happening was he ended up following, he tried to go back to work and headaches, eye troubles, eye strain, nausea. And he came back to our clinic, MAC Concussion care, and he said, you were right. This is serious. And he was a patient of mine for, he did he get back to work? No, he actually ended up, he was a patient of mine for about 2 to 3 years. And we had to treat migraines, we had to treat anxiety, depression, and he ended up on disability, long-term disability, unfortunately. But that's a case where I knew, right, within 24 hours of the accident, this is going to be a Bronco bucking ride. This is going to be tough. And I level with the guy, and it's like, somebody be looking at this guy's nuts. He's telling me I'm going to be out of work for 6 months. And is he crazy? But I just level with him because I figured then if he leaves there and doesn't get help, he at least was told, you have a severe concussion. You're going to probably be playing around with this for a bit. And it's good to hand that to somebody. It might shock them when you say that, but at least they're, okay, I better take this seriously. And what do you want me to do? I need you to follow with a place with a toolbox. And I need you also to get into therapy immediately so we can get working on it.
Yeah. Gosh, I wish somebody would have told me that right away. Nobody wanted to tell me any kind of time frames, and I didn't know any time frames. I at that point I had no idea, and I didn't even have any insight into my own symptoms when I first went in, which I'm assuming is kind of like your cop patient as well. He probably didn't realize all that he had wrong, and that's where a lot of people get into trouble. Is that depending on the level of injury, they might not even be aware that they have issues.
Correct. And in all fairness to the ERs, and that's why the education of the VOMS exam, that little VOMS exam, if we can get the emergency medical training residency program, Society of America on board, that 5-minute VOMS exam would be huge. It would be absolutely huge because I have a brother who's an ER doctor. No offense to my brother and the ER doctors, but they're only excited if you have a brain bleed.
Yeah.
You get a cracked skull or cracked facial bone, they are excited, man. This person's going to get admitted. This is an exciting case. You're not going to go, whoop, get out the door. But if you look good, no laceration to staple up, no big giant hematoma, bulge or egg, you look good, your CAT scan's negative, whoop, get out the door. And they're doing their job because their job is to identify the life-threatening stuff, treat it there, stabilize, put in the hospital bed. That's their job. So concussions kind of, it's falls between the cracks. And again, train a simple VOMS exam. If I had my Christmas wish, it would be that VOMS exam becomes mandatory for all family physicians, all pediatricians, all internal medicine doctors, all PAs and NPs in those fields, and emergency room doctors. That would be my Christmas wish. And if that happened, then we need a lot more of you and me to take care of the volume. But hey, that we can fix. That's something we can take care of. Yeah.
So on your list of tools that you use, I do see a SPECT scan. Where does that come into play? So CT and MRI don't help, but how can a SPECT be useful?
So SPECT is actually a functional study. It shows where the metabolism is occurring normally, where it's underactive and where it's overactive. So the way we got into the SPECT scan, everything that we've picked up in our toolbox has been literally through clinical experience. So when we picked up the BrainScope, we wanted the BrainScope EEG because A, it was only $500 per study, so it's cost effective. B, the insurance companies go, we'll pay for that. That's a lot cheaper than an MRI. Okay, so we got them to pay for it. But the BrainScope can identify which patients, and this will get to the SPECT scan. I'm not trying to take you on a tangent here, But again, when boom, boom, the brain gets hit. So my hands are the brain, my fingers are the nerve fibers, just to simplify it. So when that rear end collision occurs, boom, boom, we want to know, was it enough force to break nerve fibers? It's also known in the scientific world as axonal shearing. Okay. When you break the fibers in the brain, guess what? They don't grow back. They don't grow back. So the only hope you have is, well, you have 80 billion nerve fibers. So let's just say, boom, boom, you axonal shear or break 100 million nerve fibers, which sounds horrendous, but you still have 790 billion, 900 million left. So the whole purpose of therapy is when you break nerve fibers, you have to find therapies that'll take the healthy fibers running parallel to the broken ones and recruit them to be able to get the function back lost from the broken ones. Okay. And there's all kinds of therapies and all kinds of training for this. This is very, very intense stuff, as you probably have experienced. Now, we hit a point in our practice, we were like, Darren, these people are over 6 months. I wonder if they broke nerve fibers. So the reason why we brought BrainScope in, and this is where there's a lot of misunderstanding. BrainScope is an amazing device. It uses algorithms in a handheld device. It actually kind of looks like this. And the BrainScope, you put the little leads on the head, and you have a little monitor. The monitor was developed for the Army, for the Iraq-Afghan war. And what they needed to do, and this is, again, a little back explanation how we got into BrainScope EEG, they needed a device that when an ID exploded, which happened all the time in those 20 years of the Iraq-Afghan war, they're unconscious. Best you have is a medic out there. You're not going to have a neurologist, okay? You're not going to have usually even a flight surgeon or a doctor. And do we need to call a helicopter in? Because there could be a brain bleed. This person's not, they're unconscious, but they're breathing. Their ABCs are good, but they're unconscious. So what they did was they said to the BrainScope company in Bethesda, we need a device that's portable, the medic can carry to the field, that can identify if there's a bleed. They said, oh, we can do that. We're going to create a study which can take the electrical activity from 7 leads and compare it, the pattern of those 7 leads, to a person that's normal and healthy. And if they don't match up, we call it a structural injury classifier as positive. Send a helicopter with the medics and nurses, scoop them up, take them to a CT scan. And they found out when that test was negative, the BrainScope was negative in the field, it was 99% accurate. So if you had a negative BrainScope, you were 99% sure this soldier will not die. They have a concussion. You want to bring them to the medical area to start treating the concussion, but you don't need to fly them out to save their life. Now, that's a pretty fancy story for the one tool in my toolbox. But it came to us because we were like, MRIs can't see broken fibers. You know, it can't even see CTE. CAT scans can't see broken fibers. We were like, we need something to identify who has broken fibers. So BrainScope, when it was so successful in the arena of the Iraq-Afghan war, they brought it back to the States and put it in the ERs. Now, you don't see it in every ER, okay? They found certain ERs that were up on technology. But the purpose in the ER, they got it FDA approved that if someone came in and they thought there was a brain bleed, they'd do the BrainScope first. If it was negative, 99%, then they don't have to do the CAT scan, saving all these people from 250 chest X-ray radiation exposures every time they spin them in and out of the CAT scanner. Worked great. Just didn't take to all the insurance companies, I think, because the ERs are like, CAT scan I can get done in like 5 minutes. I don't want to put my nurse over there for 30 minutes with a BrainScope EEG. So it kind of didn't survive that part. Then BrainScope was, you know what? We're going to get it approved for concussions. So they're up to 6 FDA approvals. We picked them up during that evolution where it could be used for concussions. And we knew the reason why I picked up leads is because the brain and the nerve fibers are like lanes on a highway. They don't carry cars, they carry electrical signals. But if you break them, it's like taking lanes out of the highway. You are actually impeding the flow of the electrical currents. Let's take that into a more understandable world of cars and highways, okay? BrainScope is like Channel 6 Action News Action Cam, flying around our city of Philadelphia going, ooh, there's an accident on 95, they're down from 4 lanes to 2 lanes, give yourself extra time, and that's what you hear on the radio, and that's helpful, right? Or we have something called the Schuylkill Expressway, also known as the Shortkill Express. It's a disastrous road for accidents. Schuylkill's backed up, not moving at all into the city, eastbound, find another road. So just like the Channel 6 Action News helicopter action cam says, hey, this is what you need to do this morning. This is how the cars are flowing and not flowing. The BrainScope does the same thing. It literally says, there's a flow problem. There's a structural injury. It's either going to be blood on the highway, which would be like a flooding. There's a downpour. Action News is probably saying, it's raining cats and dogs. You better give yourself extra time because those cars are barely moving on 95. Okay. But the reality of it all is that it also can be done when you lose lanes. You don't have to have a flood, or in the case of the brain, a bleed. All you need to do is have broken neurofiber lanes, and they're positive. So we entered in with this tool, this new tool, very slowly. It took us almost 2 years to really see, is this going to help our patients or not? But number one, almost every single patient that had objectively measured abnormalities and deficits at 6 months, every single one turned positive on BrainScope. Every single one. So when I first would walk in and go, your BrainScope's positive for structural injury to your brain, they either ran out of the office crying, they hung their head and felt like in shame. And I'm like, oh, I got to figure out a better way to explain this, because I'm not doing good for these poor patients. I'm psychologically wrecking them. But I needed that data so I could say to them, you're going to take a while. We can get you back to work, but you're probably going to still keep doing therapy. And these medicines we started you on that are helping you recover and helping you sleep and helping you anxiety, depression, you need to be on probably for another 6 months or a year. So it allowed me to tell the patients, you're one of the broken fiber people, which is going to take longer. I got plenty of BrainScope positives that are back at work, went back to school, even went back to sports. So it's kind of thing where it was a measurement tool that we really liked. We had these patients that were smart, and they said, okay, you told me my neurofiber is broken. Where in my brain are they broken? And Dr. Schaller had his little old model there and going, I don't know. Because the BrainScope, unlike the Channel 6 Action News that says it's 95 north, or the Schuylkill heading into the city, the BrainScope just says plus or minus. And because it was originally designed just to, do you need to fly them out of a battlefield or not? So that was its limitation. It can say who has broken neurofibers, who's going to be a tough recovery, but it doesn't say where and how much. So in comes the pandemic. And we're doing a lot of telemedicine, and we're sending out our Creyos tests and our sway tests remotely for people to take. And we get a phone call from Bethesda, and they said, you're doing the most BrainScopes east of the Mississippi. I said, wow. I said, well, it's working for us. That's why we're using it. He goes, do you know who else is doing as many as you're doing? And I said, no. And they said, University of Toronto. I said, huh. I said, what are they finding up in University of Toronto? He goes, what you're finding. People that have unresolved symptoms are turning positive on BrainScopes. And like you, because we've heard your concerns, they're looking for a study to find out where and how much. And I was like, oh man, I got about 250 patients that really want to know where and how much. So I said, they go, we're going to link you into their conferences. So I would do like every other week, it was Tuesday night, every other week, I would go into their conference Zoom, pandemic, can't cross the border. So they started showing me these images, these beautiful images on SPECT Scans. And I was like, so explain to me how this works, because I'm not really, I checked out functional MRIs, it wasn't reliable, couldn't really help you. Tell me how this works. The irony of it all is that they use a technetium-99M isotope. So it's a quickly decaying radioisotope. It's been used for cardiac studies since the 70s. Okay, so it's safe. And the reason why it works for the brain like it works for the heart is because the brain and the heart are the two organs in the body that run on pure oxygen and pure sugar. Okay, and that's why when your oxygen levels drop in an asthmatic, you pass out. And if it continues, you can have a cardiac arrhythmia. Okay, that's why a diabetic, sugars plummet, they go into a diabetic coma, brain again shuts down, doesn't see the sugar, heart can get in trouble. So the same metabolic study of the heart to see where in the heart was damaged from a heart attack with a stress test, technetium-99M, works on the brain as well. So I said, I don't think they're available in our area, but tell me more about this. And they started showing me these images. And the one that fascinated me was, I said, every patient we have that has rage, and I know that rage is an overactivity of the limbic system. I said, everyone that has rage has a positive BrainScope. Every single one of my patients that struggles with rage has a positive. What are you seeing on the SPECT scan? It was like one of my first meetings with them. I said, what are you seeing? They go, oh, the limbic system lights up like a Christmas tree. I said, you're kidding me. And they go, no, we can actually show you images where it lights up like a Christmas tree. And I was like, whoa. And so they're showing me image after image, case after case, positive BrainScope, worthy of getting a SPECT scan. They go, we're working on a study. We're going to publish it when it's done. And they were working with a bunch of universities in the US, along with University of Toronto. And they published, I think it was it was like September 2023, but they finally published a beautiful article. It says, if you have a positive BrainScope, we are 97% sure the SPECT scan will show you where and how much. So now I'm like, okay, maybe I get the insurance companies to do the BrainScope they're already paying for $500, And the ones that are positive, maybe they'll let me do the SPECT scan. And so I figured that might be where my patients can finally get access to it and they can know where and how much. Well, it turns out where it's during the pandemic, so can't send patients up to the University of Toronto, be part of the research project they were doing up there. So it ended up where one of my patients did a lot of research and found out that there was a chain of brain SPECT scan centers in the US called Amen clinics. And my patient told me about it. I was like, well, guess that's a dead end. No one's going to pay for it. And I can't fly them up to Toronto. It's the pandemic. But she ended up finding, because her son had a really bad concussion, multiple skateboard accidents. And she did one better. She found the Delaware Brain Injury Fund would pay for any test that the insurance refuses to pay for. So she was my first test case. She went to the insurance with my letter. The insurance said no. They sent a rejection letter back. She handed the rejection letter and my prescription to the Brain Injury Fund of Delaware. They paid for it. Now, I had to do a little magic. I went to the Amen clinic and I said, this 6,500 is not sustainable. And I said, 6,500 is not sustainable. I said, I'll get nobody to be able to afford it personally, or no insurance, no law firm that's helping that patient pay for it. I said, you got to get it down. So I was able to fortunately get it down to half that price. And so when they did that, the Brain Injury Fund says, we'll pay for it. And lo and behold, we had 60 people use the Brain Injury Fund. And the results were just astounding. People with rage had injury to the frontal lobes, because the frontal lobe is supposed to tell the limbic system, the primitive brain, to calm down. So we were able to understand where it was coming from. People that had ringing of the ears, injury on the temporal lobes, hyperacusis, injury on the temporal lobes. People with a lot of memory problems, word find, nomic aphasia, injury to the frontal and temporal, where most of the memory is housed. It just went on and on and on and on. And we found people that the cerebellum, which is really fascinating on the SPECT scan. I don't, it's hard to put the images in front of you on the SPECT scan. It would be but I'd be happy to maybe do something where I put it on a big board and we can talk about it in the future. But the cerebellum is a very interesting involvement in the SPECT scan. The SPECT scan proves it. The cerebellum, just we think of the balancing organ. If it's off, you have, Parkinson's or whatever, you're not in balance. But the cerebellum is the busiest, most active center of the entire brain. Frontal lobe, temporal lobe, parietal lobe, occipital lobe in green, cerebellum. When you actually look at the metabolic activity, this guy is like headquarters. He takes signals from the frontal to the temporal, back and forth into the deep brain and all. So the cerebellum should be the hottest part of the brain. We were finding patients who, when they would do a test, so day one is they do a test, take a test and see how the brain's metabolizing. Day two, they go to a hotel overnight, wash out, come back the next day, see what it is at rest. We have seen patients whose cerebellums were like half active, and then when they went and took the test, went to almost zero activity. And we were like, wow. And what we realized is then the Amen Clinic said, yeah, we've been seeing this for 30 years. And I said, how did you do this? Did you do this like the University of Toronto with BrainScopes and then SPECT scans? They go, no, Dr. Schaller, we've been doing SPECT scans in the US for 30 years. I said, where have you been? And they said, I go, why are you doing them? And they've done like, I think 30,000 or something crazy number of SPECT scans. And they said, oh, Dr. Amen has an interest to find the pattern of metabolism in the brain that is the explanation for ADD, which would be a frontal lobe problem, is the explanation for bipolar, schizophrenia. So he's a psychiatrist. He was coming from the psychiatric end. And he noticed over those 30 years, there's asymmetry. What's that? Why is the right frontal lobe more active than the left? Why is the right temporal have a big giant shadow in it of underactivity versus he started realizing, oh, that's injury. So Dr. Amen, over those 30 years, came through the back door and said, oh, these are injury patterns. Toronto goes, we got these BrainScopes like Schaller has, where and how much? And those two came together, and it's been wonderful ever since. So a SPECT scan, though, back to your original question, your SPECT scan became a valuable tool when we realized we had all these positive BrainScopes. We didn't know where and how much. And then when we found out that the cerebellum was underactive, the Amen Clinic goes, you know what we do for underactive cerebellums? I'm like, no, what do you do? They go, hyperbaric oxygen therapy. I had never heard of hyperbaric oxygen therapy up until that point. And I said, let me do some research on that. And so I started to do research, and the results are incredible. It increases cognitive problems. If you're doing cognitive therapy, throw in some HBOT, really helps speed along cognitive recovery. It can be taken in someone who's 5 years out and hit a brick wall 2 years ago or 1 year ago. And the next thing you know is it re-energizes the brain. And the hyperbaric oxygen therapy opens up an entire, I think it was originally found that it really helps the cerebellum in balance. So we tried it on an imbalanced patient. We had an imbalanced patient who was driving his HVAC van, was hit by a box truck and rocked in fan, broke the HVAC unit, and really bad impact. And his insurance company goes, he's fine. He wasn't unconscious. He looks good. He's making it up. He's faking it. Well, what they didn't realize was he was a Harley Davidson enthusiast, and he would go to Sturgis and he'd go to Bike Week. And he was about to retire in a year or two, and his passion was his Harley. Well, what they didn't realize, the insurance company had said he's perfectly fine. They didn't realize that he had a positive BrainScope, and he had a abnormal SPECT scan with significant decreased activity in the cerebellum. So we said to him at that point, we finally had our first HBOT chamber in place. We said, if you do this for an hour, 3 times a week for 60 sessions, it should help your cerebellum get traction. Well, this guy, he's now 3 years into his injury and recovery. He even settled with the insurance company. They put all that behind him, and he still can't ride his Harley. So what he was doing all that time, he'd come into a visit and go, take the Harley out every week for a spin, and I get so dizzy, I got to come back in the garage and park my Harley. And I said, oh, man, I can't believe that. You're about to retire, and you can't go to Sturgis anymore. You can't go to Fort Lauderdale. And then he said to me, he goes, I'll try this HBOT. You say it's going to help my balance. I said, oh, the Amen Clinic people said it helps balance. Let's give it a try. He did 3 times a week. I think he got around like 9 sessions. He hops on his Harley. He goes around the neighborhood and doesn't get dizzy. He gets to, I think, 15 sessions, 16 sessions. He's working towards the 60 number. And he takes his Harley and he rides around town. And when he got up to about 30, because usually the goal is 40 to 60 sessions, 1 hour, 3 times a week, he got up to around 30. He took his wife out. She rode on the back, and the two of them took the Harley out to Gettysburg, which was like about a 2.5 hour ride. And they spent the weekend at Airbnb and came back. And I was like, my jaw dropped. I was like, I was like, it helps balance. So anyone on a SPECT scan with an underactive cerebellum, or anybody whose sway test is completely messed up, even without a SPECT scan, let's try some hyperbaric. And oh my goodness, we've seen case after case with hyperbaric. It's just been wonderful. Problem is that the research is about 15 years solid on HBOT and TBI, but the FDA hasn't approved a new use for HBOT since 1974. So my patients can't wait another 30 years to get access to HBOT. So we create our own HBOT program, soft shell HBOTs. We got the price all the way down to $50 an hour. It's not a big moneymaker, but hey, my patients are getting access to yet another. My toolbox has another drawer in it now with HBOT and all the different uses it can have. So we've been able to finesse it that way. And sometimes the insurance will, or the insurance won't cover it, but sometimes they're in the middle of a legal case. We'll just charge $50 a session. They can pay us at the end. Anything we can do to get them access. Because if you're not working, you're losing a ton of money.
Yeah.
Okay. And so if we can get them back to work quickly, we can get the guy on his Harley, we can get somebody back to work in front of a computer screen and get back to their salary. And that's a game changer. And personally, I mean, it affects your personal life, your hobbies and things like that. People who are mechanics and have problems with depth perception off from their concussion, they fumble with the tools and they drop the spark plug. And I mean, it affects everything. It really does. Not just profession, not just academics, but just personal enjoyment.
Mm-hmm. Yeah. And if you're a nurse practitioner and you need to get back to work.
Absolutely. Absolutely. And it affects possibly, I hate to say this, but 17,000 patients later, we almost always have 5 or 6 people living in their cars. It is so sad. And these are 5 or 6 people that had houses, that had, families, and they're living in their cars. And when you see that happen, you never stop fighting. You never stop reading journal articles to find a better way. And so those patients really motivate me when I have to read another journal. I read about 20 to 30 journal articles a week now, and all neuroscience. And that's how I found BrainScope. That's how I found RightEye. RightEye was actually an article came out and said, hey, we can track the eyes with 120 pictures per second infrared camera. And I'm like, what? And I started researching. It goes, and it's accurate. The research behind it was solid. And so I was like, ooh, let me try that. And then the next thing you know is that BOMS exam, all of a sudden there it was. I can put in the camera real quick for you. This will blow your mind. The VOMS exam, actually, this is kind of good. I'm going over this because the VOMS exam that I'm asking you on my Christmas wish list for everyone to learn how to do is based on this premise. And this premise was understood over 30 years ago by professors at University of Alabama, professors at UPMC, Pittsburgh, where I trained, and professors from Mass General Harvard. They knew this 30 years ago. So why aren't we doing it in the ER 30 years later? That's what drives me crazy in urgent care. But here's the premise. Each eyeball, can you see that okay? Each eyeball has 6 muscles. So if you have a concussion and go to your eye doctor, they're going to go, oh, you're fine. Your eyes are fine. You have no glaucoma. Your retinas didn't tear from the accident. You just need a little change in your prescription. You're good. But what they don't tell you is what's happening with the muscles outside the eyeball. So the biggest problem when someone goes to an eye doctor is they come back and say, Dr. Schaller, they said, I'm perfectly fine. Nothing's wrong with my eyes. And I'm like, nothing's wrong with your eyeballs and what's going on inside. I'm looking at what's happening to the muscles anchored to your eyeball that anchored to your skull. So the right eye has 6 muscles. You're looking at it from the lateral view. If the brain wants to look up, pulls this muscle, relaxes this muscle. Brain wants to look down, vice versa, wants to go sideways. So there's 6 muscles on the right eye, 6 muscles on the left eye. Here's the problem. Poor brain's got to coordinate these like a puppeteer with a marionette with 12 strings. Okay. And to do that, the brain has to be on its game. You whack the brain with a rear end collision, smack it in the sport or something like that. First thing that happens is its ability to control these 12 muscles gets significantly impaired. Okay. Before we had infrared eye tracking in right eye, and Oculogica, it's another company. Before we had infrared eye tracking, we had to count the wiggles. When their eyes went back and forth between our 2 fingers, we had to see, did it wiggle every beat? Did it wiggle every other beat? Did it wiggle every third beat? And they taught me at Pittsburgh, count the wiggles. That's part of the VOMS exam. Okay. But check out what right eye did. It's just fascinating. When I first saw this, I almost fell off my exam chair. You see this red circle there?
Yep.
See that blue circle there?
Yep.
This is actually what the right eye is doing in red and left eye is doing in blue, following a moving target on a screen that's going in circular motion. And this is infrared, 120 pixels a second, showing you exactly where the eyes are. They're perfectly synced. 6 muscles here moving beautifully, 6 muscles here moving beautifully, perfectly synced. This is a healthy brain doing a very important task. Check out what happens when you have a concussion. Bam. Those muscles are in total chaos, fighting each other. The eyes are aching when you're trying to read or trying to drive. Okay. They also check to see, this is called fixations. Can both eyes hold steady while you're threading a needle, while you're handwriting, while you're working with tools. This is a healthy brain holding 6 muscles on the right eye steady, 6 muscles on the left eye steady. This is what happens when you're concussed. The right eye's bouncing all over the place. The muscles are going, I can't hold steady, can't hold steady. Brain, help me hold steady, can't hold steady. Left eye doing the same thing. These are people who literally, they're having this problem post-concussion. Good luck trying to read when your eyes can't hold steady on the word as you're reading across. So there's 3 categories on right eye, which is the 3 categories we see on the VOMS exam. Fixations, can you hold it steady? We check with near point convergence. We bring a target in and see where they double the vision. Depth perception and fixations, fine motor skills. Second category is called saccades. How well are they reading? Can they follow word to word to word across the page? Can they go up and down on a computer screen? If they're concussed, they might look more like this. If they're doing this, then they're not comprehending what they're reading. So if they're trying to learn a new task at their job or they're trying to learn a new course in school to pass a test, they could read for an hour and don't retain anything because their eyes are doing this as they're trying to put it, because the brain has to grab the word. Think about how we read. Grabs the word, boom, 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 builds the sentence, processes the sentence. But if you can't grab each word or you're never going to be able to understand. It never gets to the brain to process it. So you got some people who are like, Dr. Schaller, I was in a lecture all day in my math class and at the university, and I walked out of there. I don't remember a damn thing that the professor said. Well, it's because his eyes were jumping all over the smartboard. Or over the chalkboard. So and so these things are real. And when you can measure them, the cool thing is that I can show you on another day, I can show you literally, look how abnormal these tracings are. Ocular Therapy. Woo! Oh my God, that's in just 3 months. It's getting back to normal. And when you get all this back to normal, then you can go graduate the patient. Get the migraines under control. Eyes are tracking beautifully. Sleep's good. I can taper off the sleep medication because it sleeps back to normal. We use our medications as bridges. People have to understand that. When they come into our office, we put you on Lyrica gabapentin, cool the brain down so we can push therapy. But guess what? When you're recovered, they're coming off. We can put you on Ambien, Sonata, or the newer ones, Dayvigo, Belsomra, and Quvivic. But guess what? Once your brain is sleeping well, we're going to taper them off. So do you know why you can't sleep after a concussion, or why it's problematic? Do you understand why? It's a fascinating.
I don't know that I do.
The fascinating physiology here. When you go to sleep, so if this is like a graph of sleep, okay, deep sleep and shallow. This is awake. Shallow sleep is 1 and 2. You maintain 1 and 2 long enough, nobody wakes you up, blows a horn, turns on the lights. You go down to 3 and 4 deep sleep. 3 and 4 deep sleep, so this delta wave. When you look at the EEG, it's sinusoidal wave. It's like I-95 at 1 o'clock in the morning with very few cars. Okay, that's deep sleep. That's when the brain refreshes itself, recharges itself. Then 3 and 4 pops up to REM. Dream a little bit, then it goes back down to 3 and 4, pops up to REM. Some of these smart watches can actually tell you how much time you're in deep sleep, 3, 4, how much in shallow, how much in REM. So we actually can detect this now, which is really cool, especially if you're treating a concussion. Here's the problem with a concussion. We talked about broken nerve fibers and bruised nerve fibers, right? All 80 billion nerve fibers have to send a signal down to mission control in your brain, and it has to be a clean signal. Okay, here's the problem. Break enough nerve fibers, axons, those fibers can't send a clean signal. And guess what mission control is hearing from that injured area of the brain, which we found out was there on the BrainScope, confirmed where it was on the SPECT scan. The mission control is hearing static 24/7. So when you're trying to fall asleep, stage 1, 2, you're ready to go to 3, 4. 1, 2, 3. So why do we use ambient lunescent sonata? Yes, they do sleepwalk. Yes, they can sleepwalk 1 in 100, sleep eat 1 in 1,000. So you have all kinds of great internet stories that might say, oh, you're on ambient, you're on lunescent. Oh my God. But the reality is Dr. Schaller's treated thousands of patients for 30 years. No one's jumped in a car and ran outside and got hit by a truck. Those are stories where they had a few beers and a bunch of Ambien and did something stupid. Okay, but here's what happens. You get down, we'll pick on Ambien because that's the one that's most used. They go down to 1 and 2, static goes, Ambien goes 3, 4 with Ambien. Up, 3, 4 Ambien. We have people that walk in 3 months after their concussion. They can only sleep like 2 to 3 hours a night. Put them on ambient lunescent sonata or one of the newer Dura drugs, and they're getting 5, 6. They're like, oh my God, I'm sleeping so much better. Well, guess what? Try doing rehab on 2 hours of sleep at night. Mm-hmm. The battery doesn't even take a quarter charge. So you take that person with poor sleep and throw them into vestibular and ocular therapy, they're going nowhere because they're not sleeping. And we picked up another really cool study from the University of Boston. They did a phenomenal study. They took a radioisotope, like we did the technetium-99M with SPECT, but they labeled a molecule in the cerebral spinal fluid, a molecule that would zing into the cerebral and would literally isotope would run in and attach itself in the cerebral spinal fluid. They took motion pictures. It's really fascinating using their Geiger counter, and they actually watched cerebral spinal fluid in the conscious day flows like really slow, like the lazy river at the water park. Okay, real slow. In stage 1, 2 sleep, a little faster. Stage 3 and 4, like the rinse cycle on your dishwasher, washing away toxins, bringing in nutrients. So if you're not getting enough of that deep 3, 4, not only are you not charging the brain in delta wave, you're not flushing away all the toxins and bringing all the nutrients. So the study in the University of Boston was fascinating. When I saw that, I was like, it recharged us to say, yes, this is what we're doing with our sleep aids to try to help someone through the concussion. And what's fascinating is that you ever have that morning you wake up and you're like, oh, that was a good night's sleep. That was a good one. You had a ton of 3 and 4. You had the rinse cycle going full steam ahead. You had good architecture of sleep. And so that's the reason why I said, and so sometimes it's sleep alone. They come to us, they don't want any medicines. I have patients, I want all vitamins, no medicines. I'm like, let me tell you about the story about the sleep cycle and rinse and the stages 1, 2. And when I'm done, they're like, okay, that one I'll try. and sometimes that's the game changer. Then they can go back to therapy and they can start progressing. And we don't demand people use prescriptions when they're needed. We recommend it. And I'll be honest with you, if they need gabapentin Lyrica to cool the brain off, nerve modulator, and they absolutely refuse to take it, it's about 3 times longer recovery. So it's kind of like, I'm not going to twist their arm and hold a gun to their head, but I can tell you it is incredibly different when you put in a nerve modulator. The recovery, it's so much more predictable. It's so much quicker. So in our toolbox, prescriptions to cool the brain off, prescriptions to help you sleep, prescriptions to treat anxiety, depression, because anxiety, depression, if you don't have it, you might get it. during for the first time during a concussion. If you have it, it's going to spin out of control. So, and that brings up an interesting point. Have you ever heard about the trifecta of concussion pre-existing conditions?
Recently, yes, unfortunately. Listeners probably haven't, yeah.
Trifecta, number one, if you have ADD before the concussion, your meds may not work so well anymore. You're going to need some changes, but you never stop your ADD meds because that chemistry was figured out before the injury. You might need to tweak it, maybe change the dose or something. If you have pre-existing migraines, good night, Irene. Those migraines that you haven't seen in the last several years, maybe have once or twice a year and take a sumatriptan. Now it's every day. Okay, they're vascular headaches and they're every day. Number three, anxiety, depression. So when a patient walks in my door on day one, had ADD as a kid on Adderall, had anxiety, depression, maybe even postpartum, but not on any meds right now. They're able to work their way through that, and has a history of migraines that maybe they had as a teenager, and maybe they had a few flare-ups where that takes. They have all three of those: anxiety, depression, migraines, and ADD. I look to myself and I'm like, this is gonna be a long one. So this is 6 months, a year, or possibly longer, because we're gonna be chasing migraines and try to control them with all the new medications, the CGRPs we're gonna be chasing migraines probably for a year plus. And then anxiety, depression, get back to your counselor. We're in it for a bit of a rough ride. Let's look at your medicines. Let's see if we can adjust them. So, but that trifecta, and if you have a one unifactor or bifactor, that's a problem. Someone walks in with ADD, you're going to have a more complicated recovery. When all three are there, my goodness, I do honestly sit down with the patient and say, you do understand, this is not going to be weeks. This is going to be months. This could even be years, and they're okay with that. As long as you level with them up front, and then there are no surprises. So and here's the best part with my toolbox. I can show them, look at your sway test. It came up over the last 3 visits. Hey, look at your Creyos scores, the ImPACT scores. They're coming up nicely. And they love that, so it's not wasting my time with all the stuff I'm doing with you guys in therapy and all. Here's your right eye. Remember how it was all messed up? Now look at it. It's starting to clean up. So we can literally sit down in a visit, show them all the updated test results, and they can go, oh, at least I'm getting better. Because some of these people are thinking, I'm never going to work again. And we're like, no, that's too quick of a judgment. But can I work next month? We're like, yeah, probably not. It's going to be it could be longer than that. But hey, if I can show you this progress and show you plateau off, I hope that when you plateau off, you can go back to school, you can go back to work. I hope you can play a sport. And in sports, we hate to tell someone to stop playing contact. We like it to be their choice. But the reality is, if you've got an abnormal right eye that won't clear up, if your tracking moving targets is still erratic after a year of therapy or 6 months of therapy, if you're positive BrainScope and you're having migraines every day, we're going to have that talk. Okay. And if it's an adult over 18, they can still say, I'm a boxer. That's my life. I'm going back. You at least get educated and you at least treated the concussion. So when it comes to athletes, if they're over 18, man, it's going to be their call, but they're going to go when eyes wide open. Your next box in the head could be migraines for life every single day. Your next hit in the head could be horrible anxiety, depression, which will make you suicidal and will be restless. So we have to try to explain that to them. We really do. And the number one cause of death in our patient population at MAC is suicide. Number one cause of death is suicide. We've had over the years, we probably had about 24 people attempt it. We've sent people to the hospital, to the ER, to be addressed immediately. We even called their psychiatrists or psychologists while they're in our office if we're running into trouble. So, but the number one cause of death in the TBI world, concussion world, is suicide. And unfortunately, you will bear witness to that in the media. College kids killing themselves, and they were the best soccer goalie, that young lady up at Stanford. People just like NFL football players. It's pretty much every month or every other month. Committed suicide, and it's like, but he was a millionaire, and he had a great illustrious career, and and then there's a whole discussion: did he have CT? Did he not have CT? The reality of it all is that if you're taking head hits, it decreases the production of serotonin and norepinephrine, chemically increases anxiety, depression. You've got to be on top of that from day one in the concussion world. Our survey asks every patient, every visit, are you feeling anxious? Are you irritable? Are you having panic attacks? Any thoughts of harming yourself? Are you sad? Are you crying when you shouldn't be crying? Every visit we ask that. And that's how we avoid the suicide. And that's how we identify anxiety, depression, because some people don't want you to know they're anxious and depressed. And they think it's being weak. But when you ask them every single visit, it literally tells them that, okay, might be okay for me to say that I'm crying at a Hallmark commercial when normally I never cry about anything. I mean, so that opens the door, keeps the door open. But there we can do better. I think our athletes with concussions, they clear the concussion, they're back, but is there going to be an anxiety depression fallout? And it could be 3 to 6 months after they recover from the concussion, they come back and their serotonin levels started dropping during the hit, continue to drop during recovery, and then they reach a critical level. So we tell all of our young athletes and their parents, keep an eye out for the next 3 to 6 months. If they get moods off, they start pulling back from their friends and all, even after I clear you from the concussion and they're back at their sport, please call me and let me know. And we have had a bunch of middle school, high school parents call us and say, I know it's been 6 months, I know you graduated us, but I think there's something going on. And we bring them back. Their sway test is still beautiful. The RightEye looks great. The Creyos test looks wonderful. ImPACT test looks wonderful. It's anxiety depression. And we put them on an SSRI, get them into counseling, and those C's and D's they were getting to school all of a sudden, they're back to their performance of A's. So we keep eyes wide open and educate for anxiety depression. That's something we can treat, and that's where we lose our patients. Can lose our patients through anxiety depression.
Yeah,
especially if you never experienced it before. If you've never been stuck with postpartum depression, didn't have problems as when you're puberty with all those ups and downs emotions. If you don't have anxiety, depression, and you're now 30 years old, you don't know what it is. And you need to explain it, educate them, tell them why it's happening, and tell them what we can do about it. And I'm very proud of my providers at MAC. They're really proactive. The surveys being filled out every visit. They're double checking with the patient on those questions. And no provider wants to have fatalities, whether you're a cardiologist or, neurologist with seizures, falling and breaking their neck. All of us providers have to be careful of the fatality. And in the concussion TBI world, believe it or not, even without a brain bleed, even with a negative MRI and CAT scan, this person could be incredibly depressed or incredibly anxious. So, and that's kind of where we take pride in that. We try to stay right on top of that.
Yeah, that's awesome. I think I have so much more to learn from you, Dr. Schaller. So you and I will definitely be in contact. Looking at the clock, that we probably should start to wrap things up a little bit. Do you, you personally or anything at MAC, have any events coming up or projects that you'd like to share with our listeners?
We're working on a Zoom lecture sometime in the summer where we'll be inviting providers, doctors, nurse practitioners, physician assistants. We'll be inviting occupational therapists, physical therapists to teach them about these technologies. And the goal is that I've always felt strongly that if you educate, things will change. And they don't change the speed you want them to change. And that's okay. I mean, that's the real world. But at least if you educate and educate and educate, I can't tell you, I've been educating to NovaCare, Phoenix, ATI, all these PT centers. I've lectured to all of them countless times in the last 10, 15 years. And not a week goes by that someone doesn't call from ATI. I did the VOMS exam on this person with whiplash and I have a concussion. Can I send them to you? Can you see them soon? And so all the time it happens. So, and then to get those centers to start certifying the providers to do concussion care, it's just priceless. I mean, it took over a decade to get that done, but it all started with lecturing. And that's why the lectures will continue. So we're getting really busy. So I used to lecture like in person, 4, 5, 6 times a year. But with as busy as we're getting, and my toolbox is getting so big, I can't just drag it everywhere. But we can do it on a Zoom meeting. And in this summer, we're looking forward to putting together a good quality lecture, getting everybody up to date. And it can be anybody, it could be international, it could be anywhere in the U.S. So we're going to open it up. Awesome.
Where can people find you if they want to learn about this lecture series or anything else that you guys have to offer?
If they go to our we have a presence on X, presence on Facebook, presence on Instagram, and our website. But if they just want to go to our website, it has all the blogs, all the teaching tools, talks about our toolbox, all the different things we're doing, including HBOT and SPECT Scan. But if they just go to www.macconcussions.com, is it concussions or concussion? MacConcussion.com without an S. But if they go to www.macconcussion.com, they can learn about all the events. And most importantly, we've been blogging very consistently with all kinds of wonderful topics. And then all the tools in our toolbox that explains each and every one, how we use them, what they look like. It's kind of fun to see the pictures of an HBOT device, fun to see what a SPECT scan looks like with the images. There's actually images on the website that you could actually go to and see where the metabolism drops in that particular lobe, or the right side or the left side. There's some really cool images we posted on the site for that too.
Very cool. And you sent me all the links to the socials, so I will include those in the show notes as well, so that anybody driving doesn't have to write anything down. They can catch all those links right in the show notes. Any last words of wisdom you want to share with our listeners before we wrap up today?
Yeah, just to educate everybody, educate the students, educate the athletes, educate the coaches, educate the referees, the officials. And I'm not talking just the NFL, I'm talking like recreational all the way up to professional sports. Educate the teachers. The teachers are in the class and the student's struggling. This is a straight A student. Oh, he plays lacrosse. I wonder if he got a hit last week or during practice. Okay, the teacher can recognize a sudden change in academic performance. Okay, educate the school nurse. They're coming down to the school nurse throwing up. One of the questions should be a quick little VOMS exam done by the school nurse. So really educate everybody. And in that way, as a community, we identify and treat. And then hopefully if you educate, they not only know how to that looks like that could be a fencing reflex. We better get them to be checked out. But also they go, and they should be in therapy in less than a week. They shouldn't have to wait 3 months. They don't have to wait until they're symptom free, but they should understand what good therapy looks like. And then they should have an understanding that it works. It's accepted by the PT community. It's accepted by the OT community, even if it's not what they're told to do at their ER. But to know what to expect. To know when they go in the ER and CAT scan negative, have a nice day, bye. Go see your PCP. They know that, well, of course they couldn't tell that I had a concussion by a CAT scan. So all of my PCP work with me on that. Hopefully PCP has a toolbox. Hopefully they do a VOMS exam. And that's where all the education comes from, that we want to make it a faster diagnosis, quicker to treat, and then back to the world fully recovered is really what we want.
Really good goal. And you and I share that goal. So I'm excited to learn more from you and do some more education myself. So thank you so much for being here, Dr. Schaller.
You're welcome. My pleasure.
Thanks for tuning in to this episode of Brain Wellness, the podcast. If you enjoyed this episode, I encourage you to subscribe, like, and share this with others to help me continue on with my mission to help people live healthier, happier lives. Go to www.brainwellnesssolutions.com to see what I'm up to and get links to all the social medias there. See you next time.